As the name suggests, it is diffuse axonal injury, but it is not truly diffuse. So it was described as early as 1956 by Stritch in autopsy specimens, and he showed axonal bulbs that were called Stritch lesions. And it was not till 1982 when Adams described like three different grades of traumatic brain injury along with its pathology. And generally, in 1983, described the mechanism which is responsible for diffuse axonal injuries. And CT scan classification of diffuse injuries, not diffuse axonal, but diffuse injuries was described by Marshall in 1990. So currently we don't use word diffuse axonal injury. So this is NINDS definition of diffuse axonal injury. It is called traumatic axonal injuries because it is not as diffuse as the name suggests. It occurs in a very specific pattern. So TAI is basically multiple scattered small hemorrhagic and or non-hemorrhagic lesions alongside brain swelling in a more confined white matter distribution on imaging studies, together with impaired exoplasmic transport, axonal swelling, and disconnection after TBI, with more than three such foci present on the imaging studies, can be classified as traumatic axonal injury. So the mechanism which lead to traumatic axonal injuries can be either direct impact or accelerative and decelerative forces. And these forces in coronal plane are primarily responsible for axonal injuries. And there may be combination of translation as well as angular acceleration. And sometimes even rotational acceleration also contributes to it. Traumatic axonal injuries can be caused by traumas with relatively low rates of acceleration, like in bicycle accident, there is no high acceleration deceleration, but still it can occur. And even deadly traumatic axonal injury can occur even if the initial impact force is not strong enough to cause fracturing of the skull or evident macroscopic pathology in the brain. This is important in forensic pathology like car accidents. There may not be any impact, visible impact on the head. There may not be any skull fracture, but the patient dies due to severe traumatic brain injury. And on gross autopsy, you may not find any great pathology, but there can be traumatic axonal injury. So same acceleration, deceleration forces, if they are of very short duration but high magnitude, they cause acute subdural hematoma due to tearing of the vein. Whereas if they are of longer duration, that is 25 milliseconds or more, they will cause traumatic axonal injury. So traumatic axonal injury shares some biomechanics with acute subdural hematoma as well. So this is what happens like in case of less rotational injury, there may be just twisting and partial disconnection of axons or no disconnection. There may be just block of the axolemal flow. But further deceleration acceleration forces can result in primary exotomy or actual disruption of the axons, which results in neuronal death as well. And such patients may not have any potential for recovery. So primary exotomy is the process of direct tearing of the axons due to mechanical forces. And these torn axons, they retract and form retraction bulbs, which were known as stitch lesions. So these injuries you cannot see on CT scan, but when you see gliding hemorrhages on the basifrontal basitemporal region in CT scan right after the trauma, they are indirect indicator that patient may be having traumatic axonal injury. And this primary exotomy may also cause a decreased level of consciousness. However, complete primary exotomy is nowadays considered rare. Earlier, it was described that primary exotomy is the cause of diffuse axonal, but pure primary exotomy is nowadays considered. So, what is more common is secondary exotomy. Secondary exotomy is more of biological process rather than a mechanical process. So there is a hierarchy in which the secondary exotomy occurs. Like same, if you recall our peripheral nerve injury lesions like neuropraxia, neurotomesis, axonotomesis, etc. So in lesser injury, there will be just loss of axolemal flow or reversal of the axolemal flow. And then the next stage will be at the subaxolemal proteins, particularly the spectrin, which is responsible for integration of the axon, breaks and results in axonal injury. And next is microtubule. So there is disruption in the microtubule, and disruption of the spectrin protein and microtubule leads to a lot of other secondary pathophysiological processes. And here you can see blue, cyan color callouts. These are the potential targets for therapy in case of secondary exotomy. So next pathology, next phenotype is neurofilament involvement. So injured neurofilament involvement, you can see the gaps in the neurofilament involvement. With RMO is one of the antibody through which neurofilament can be studied. And like in any peripheral neuropathies, there is nodal pathology at the end, there is node, and paranodal pathology, which also contributes to secondary exotomy. So all these things do not occur at once. So first thing is primary exotomy, and second thing which is seen is alpha spectrin breakdown, which is the earliest, can occur as early as 15 minutes after. The most of the patients who come to us after injury, they will take at least 15-30 minutes. Like in China, he showed 2 hours. So by the time patient reaches us, already secondary exotomy process has already begun. So though we say primary exotomy cannot be treated, even secondary exotomy, we have very small therapeutic window to treat secondary exotomies. And neurofilament disruption occurs much later. So you have some time window like 6 hours to 24 hours. And that continues. That is an ongoing process. Nodal pathology is also an ongoing process. So here there is possibility of some therapeutic window when there is an ongoing process, whether it can be stopped or reversed. When you see pathology, when you do autopsy of this patient with traumatic axonal injury, the gross pathology, these are our own pathology specimens. The brain looks largely normal. You cannot make out anything abnormal as DHEDH. So when you cut the brain, you see the lesions. So these are the distribution of the lesions in cut brain after traumatic axonal injury. Commonest, these are the autopsy specimen. So commonest lesions were seen in the dorsolateral sectors of the upper brainstem, followed by corpus callosum, in and around the third ventricle, parasagittal region, cingulate gyrus, thalamus, and even basal ganglia. I'll show you example. Like this is an autopsy specimen where you can see the hemorrhagic lesions in the parasagittal region. Here you can see in the deep white matter in the frontal region, below near the cord, and here the gliding contusions at the basifrontal. Here in the corpus callosum with intraventricular hemorrhage and corpus callosal. So this is in thalamus, in the septum, in the temporal white matter, in the dorsolateral brainstem, again in the corpus callosum and septum, and dorsolateral brainstem. So this is like you can make out like there are two hemorrhages. There is an hemorrhage in the paramedian region as well as hemorrhage in the dorsolateral quadrant of the brainstem. So the hemorrhage in dorsolateral quadrant of the brainstem is due to traumatic axonal injury, whereas in the paramedian is due to secondary brainstem injury due to herniation. So which can be seen in Luxel fast blue stain that there is a lesion. This is a basal ganglia hemorrhage as a part of diffuse. And another common white matter which is involved in traumatic axonal injury is middle cerebral peduncle, where there can be hemorrhages. So this all are out of hospital. And even hypothalamic damage can occur with or without diffuse axonal injury. Here you can see supraoptic nucleus and paraventricular nucleus. There are hemorrhages in diffuse. The secondary brainstem hemorrhage is due to herniation, as I already mentioned, and that will be reflected as paramedian hemorrhages. This is the LFB. You can see the hemorrhage. And when the AD forces are too violent and at the lower level, even the cervical spinal cord also suffers, and traumatic axonal injury can be seen. Like here, and you can see contusion in the gray white matter junction, and there is loss of myelin in the long tract in the spinal cord. On histopathology, the common stains which we use is silver stain to look for normal axons and neurofilament stains to look for normal axons. And this LFB which can see the myelin. So this is how normal brain. Whereas in case of traumatic axonal injury, as early as 8 hours after axonal injury, you can in neurofilament you can see the swelling or axonal bulbs, and there is disruption as well as globular swelling of the. This is in fornix. And there can be focal swelling without disconnection. Actually, there may not be disconnection, but there can be focal swellings in the axons. The axonal spheroids get dilated as the time passes, and much later there will be dystrophic changes in the cortical neurons proximal to the damaged axons. This can be seen with neurofilament stain. So besides axonotomy, you can see ischemic lesions. You can see even microglial clusters which appear later after axonal injury. And this is a hemorrhagic lesion in a patient with traumatic axonal injury. So clinically, this axonal injury is present with coma. Traditionally, this was classified as mild, moderate, and severe, like 6 hours to 24 hours. Moderate coma beyond 24 hours without abnormal posture, which indicates brainstem is intact, and severe coma beyond 24 hours with sign of brainstem deficits. So this was original clinical presentation described for traumatic axonal injury, and which we currently see a mix of all. So if the rotational forces on the brainstem are on its transverse axis, they are associated with coma. But if they are on vertical axis, they are not associated with coma. A loss of consciousness can occur even when there is a small rotational force acting transversely. So it's not the magnitude of the force, it's also the direction of the force which is important. And duration of coma has been linked directly to the severity of traumatic axonal injury. However, even bilateral thalamic or massive bilateral cortical damage can also play a role in coma without affecting the brainstem. CT scan is the commonest investigation which we use, and if you are lucky, you can see this petechial hemorrhages in the white matter, like in this case in frontal white matter and temporal white matter. And carefully, if you see, there is a small, I don't know whether you are able to see, yes, there is a small petechial hemorrhage in the dorsolateral brainstem. But most of the time, you are not lucky to see such hemorrhages. Patient is comatose, and CT scan looks like this. Like, can anyone make out any abnormality in this to CT scan? So obviously, when you see in emergency room, you will spend hardly few seconds seeing the CT scan because you want to see only ADH, SDH. You don't want to see anything else to decide immediate treatment. So these scans look normal, but the patient was comatose. So this is MRI. Now MRI shows lesion in the splenium of the corpus callosum. This is the same patient MRI at higher section susceptibility weighted imaging showing microhemorrhages. So now you know why the patient was comatose. So CT scan is not a good investigation for traumatic axonal injury as you can miss a lot of lesion. But CT scan surrogates can be used to know whether the patient has traumatic axonal injury. Like if the subarachnoid hemorrhage is in midline, the patient is likely to have DAI. If there is intraventricular hemorrhage, patient is likely to have corpus callosal bleed. If there is blood in interpeduncular system, then patient is likely to have brainstem bleed when MRI is. So when you do MRI, there are three sequences which are mandatory to be done for TI in MRI, which is available in routine MRI, clinical MRI. So this is susceptibility or gradient images, so like middle. This is T2 image. Now T2 image looks largely normal, but when you do gradient, you can see some black spots indicative of hemorrhage. When you do susceptibility weighted images, you see more number of black spots and at higher resolution. So this indicates there is hemorrhagic traumatic. Then another investigation which you should ask for in MRI is diffusion weighted images, which will show diffusion weighted lesions in the corpus callosum, like in this case, in the brainstem and in the parasagittal white matter. Now, problem with diffusion weighted image, it is sensitive. You can detect lesions, more number of lesions, but they are not the permanent lesions. So if you repeat a scan after 2-3 weeks or a month, these lesions may disappear. So more important is that these lesions are not, and important imaging tool is FLAIR imaging. So in FLAIR, this case shows in cerebral peduncle there is a lesion. There is a lesion postal limb of the internal capsule. There is lesion in the parasagittal white matter and then the splenium of the corpus callosum. So presence of FLAIR lesions indicates more or less permanent injury, and they do not disappear with time. And the volume of FLAIR lesions are the best predictor of outcome in patients with traumatic axonal injuries. So conventional grading of TEI, which we have already learned in our residency, is grade 1 in lobar white hemorrhage, grade 2 in corpus callosum, and grade 3 in brainstem. This is like conventional teaching which all of us have been brought up with. So, but yes, there is some importance for conventional teaching. This is an article from European Radiology that mean Glasgow outcome scale, like in grade 1 was higher and grade 3 was lower. But this does not pick up the rest of the lesion. So there is new grading called Stockholm grading. So the grade 1 is same as conventional grade, standard grade. In grade 2, they have included unilateral lesion either in thalamus, cerebellar peduncle, single lesion in the dorsolateral midbrain, or bilateral lesion in upper midbrain, or in corpus callosum. All are clubbed in grade 2. In grade 3, there are bilateral lesions in upper midbrain or bilateral thalamic lesions or unilateral thalamic lesions in the internal capsule. In grade 3, there are bilateral pontine lesions. So it is important to see that as the grade increases, the median Glasgow outcome scale drops. So it dropped to 3.3. In the previous, you saw there was only 3 level, and you do not see more severe outcome. So even further refining of this grading was done in Trondheim grading. Grade 1 remains same. Grade 2 remains same, that is in corpus callosum. However, in grade 3, they included only unilateral brainstem or unilateral thalamic lesion or unilateral uh, basal ganglia lesion. In grade 4, bilateral lesion, but in upper midbrain and thalamus. Whereas grade 5, it is bilateral pontine lesion. So again, as the grade increases, the outcome worsens. So the importance of this, most important is if you see bilateral pontine lesions in patients with traumatic axonal injury, they are bad. So they are very less likely to have good outcome. Many of them may even die. So this is the important. Just presence of a brainstem lesion is not indicator of severity. Like unilateral midbrain lesion, patient can survive in 75% cases. Patients survive, though with some dystonia, hemiplegia, etc. So this is in the real MRI, the grading system of Trondheim. So in the grade 1, you can see there is a flare lesion here. In diffusion weighted images, there is a lesion in the parasagittal white matter. And in gradient echo or susceptibility, again, you see parasagittal white matter lesion. In grade 2, you can see in the corpus callosum, same flare lesion, diffusion weighted imaging lesion, and in the susceptibility weighted. In these are the examples of grade 3 where there is a unilateral lesion in the posterior thalamus, unilateral lesion in the brainstem, and unilateral lesion in the basal ganglia. In grade 4, there are dorsolateral, that is behind, it is away from the tegmentum. So in within the brainstem, it is not the upper, middle, or lower brainstem. It is anterior, middle, and posterior brainstem. So middle, that is the tegmentum of the brainstem, is very crucial, where reticular activating system is present. So if the lesion is not in the tegmentum, outcome may not be as severe as you think. So that's why the grading of non-tegmental lesions will be lower, whereas the same does not apply in pons. So in pons, we don't have clear tegmentum and posterior portion demarcation. Like in midbrain, posteriorly are colliculi, but in pons, posteriorly there is nothing. There is just a fourth ventricle. So the tegmentum is just below the ependym of the fourth ventricle. So though you may think this is a dorsal lesion, actually it is the middle lesion in the pons, and they are bilateral. So bilateral pontine lesions are indicative of severe injury and outcome is likely to be poor. Um, More refined structural imaging is diffusion tensor imaging, which actually detects the white matter tract. And there are various parameters which are used in DTI. One of them is functional anisotropy. It's a scalar measure. It's not a vector because it measures in all direction. And it reflects the microstructural geometry and is very high. Like FA is close to 1 in normal white matter and lower in the damaged white matter, and it is close to 0 in CSF. So based on the FA values, you can see whether there is axonal disruption or not. Mean diffusivity is overall degree of water diffusion in all directions regardless of the orientation. Axial diffusivity is the principal tensor direction that, as it suggests, is an axial with its associated magnitude. So it is more of vector unit, axial diffusivity. and it is related to more profound tissue damage in axonal loss. So when the axial diffusivity is reduced, it indicates more profound tissue damage. Whereas radial diffusivity represents the other two directions, which are perpendicular to the axial diffusivity, and it correlates more with demyelination rather than axonal loss. So if the patient's radial diffusivity is change, then you may hope that patient may recover. But if axial diffusivity is changed, then patient may not recover because there is axonal loss. So there are various ways you can analyze DTI images. One is region of interest analysis. So whatever region of interest you want, like in this case, thalamus, you can put the region of interest and do analysis of RFA, radial diffusive, median diffusivity, etc. But here you have to do yourself on your own where you want to do it. So another is tractography. So in tractography, like whole brain tractography is done initially, like you do any tractography for tumor planning or surgery. Then you place seed in the region of interest where you want to place the seed. Like in this case, this is a survivor of severe TBI with speech and language disorder. So we place the lead in the superior longitudinal fasciculus, and then do tractography only of the superior longitudinal fasciculus, and you can see the disruption. Like in this case, you can see the corpus callosum, the fibers are not going into the right frontal lobe, and same at the higher level also same thing you can make out. So you can use tractography to identify the tract and which you can correlate with the neuropsychological findings or clinical findings. Another method of DTI is voxel-wise analysis. Unlike tractography, where you have to put seed yourself, it is automatic process and requires minimal intervention from the operator, and it is less user dependent. So the software which is used is tract-based spatial statistics, which is called TBSS, is the current and the leading method for voxel-wise analysis. So the one more advantage of voxel-wise, you can do group analysis when you're doing particularly research. You can group the patient with or without deficit, normal versus abnormal. So this is an example of 20 cases of normal versus abnormal. So this will give the values also. Like in this case, the lower FA values. This is case of lower FA values. This is a case of increased mean diffusivity. This is a case of increase in radial diffusivity. And this is a case of increased axial diffusivity, which is there in the white matter surrounding. But in case of here, corpus callosum, the diffusivity was even more. So this indicates more severe injury in corpus callosum as compared to the white matter. So this voxel-wise analysis is very good for group analysis. New emerging field all of us know is radiomics, which is a method of the field of AI aiming at the extraction of quantitative features from routinely acquired imaging data not accessible by conventional image analysis. Like in morning we saw midline shift, volume. This all you are conventional and what you see and you measure. But in radiomics, it from the features which you cannot see through naked eye, it extracts, and it has been found accurate in up to 88% of the cases in identifying traumatic axonal injury lesions. How radiomics is done? The first is segmentation of the brain is done after whole brain MRI. You can do segmentation. There are atlases available like MNI atlas. So you can segment brainstem, thalamus, basal ganglia, corpus callosum, gray white matter. Then you have to do registration with MNI, that is Montreal Neurological Institute Space Atlas. Then extract the features. Like in naked eye, you see hypointense, hyperintense, something like that, isointense. But with this algorithm, you can extract features which you cannot see. Like each box, each pixel can be extracted. And then training is done. Then you select the feature and repeat that, and cross validation is done. Then testing is done. Then after testing, you can predict whether this is a DI patient or not a DI patient. So this is how radiomics is done. And nowadays, radiomics, like all of you must have used in stroke, like large vessel occlusion, AI based detection. It is very easy. Like there is no need of radiologist that will tell that is LVO, large vessel occlusion. It will give aspect score also with color maps that this is the infarcted region of the middle cerebral artery. So that is FDA approved and that is widely used. Similarly, for EDH, SDH, automatic volume measurement, automatic midline shift are also being used, but not approved yet. So with radiomics, you will be able to detect traumatic axonal injury better because it is very tedious for a radiologist also to see some 4-5 sequences each and every section to find small hemorrhage. Biochemically, traumatic axonal injury can be detected. There are so many biomarkers available for traumatic brain injury, but in case of axonal injury, these are specific to axonal injury. C-tau, neurofilament, light chains, beta amyloid precursor protein derivatives in CSF, and even HDL cholesterol is found to be higher in patients with traumatic axonal injury as compared to the patient without traumatic axonal injury. I showed you the pathophysiology of secondary exotomy. So each of the pathophysiological pathways can be potential target, and number of measures have been tried, like cyclosporine, calpain inhibitor, tacrolimus, texins, erythropoietin, progesterone, nicotine receptor, etc. So each of them act at one of the pathways of pathophysiology. That is, one is that prevention of secondary exotomy, and second is enhancing neural regeneration using stem cells. So stem cells per se do not replace neurons which are already lost, but they help in biobridging. They may help in bridging the cut axons, and they may release neurotrophic factors which will help in synaptogenesis, not from the cut axon but from the neighboring axons. So this have been found useful. You see, if you go and read Journal of Neurotrauma, every issue will have one article on one of these molecules showing benefit in rats, guinea pigs, mouse, or etc. So it is very easy to do in an animal experiment, like you measure one of these levels or you give cyclosporine to one group of rats and you don't give to another group, beat the rat, and then again cut the rat and see whether they have more external injury. But that you cannot do in human being, right? So what is happening with all these therapies is this translation from experimental studies into clinical practice is difficult, mainly because there is incongruence in the pathological timelines between humans and rodents. Most of the time, you give this drug before injury in rodents in experiments, but in human case, you have to give after injury. I cannot eat cyclosporine and go on bike daily, or thinking that if I get head injury, I will not get external injury. So there are no suitable conversion rate between the two. Like what is seen in rodents is not getting converted to humans. So
Come,
outcome
no
of
problem.
traumatic axonal injury is, if you somebody asks me how is the outcome, so it is definitely worse than extradural hematoma for the same GCS,
Look here.
but better than acute subdural hematoma for the same GCS. So it is not only the survival with whatever monitoring, microdialysis, whatever you may do, it's the functional outcome. So once there is traumatic axonal injury and patient recovers, there is a lot of axonal loss. So this results in impairment of attention, working memory, language comprehension, balance. So as surgeons, if I have treated a patient who is decerebrating, who comes walking, talking to my office, I'll be happy. A person who was dying has come walking, talking to my OPD, but that's not true. They have a lot of other problems. So so they may not be managers or surgeons or doctors or CEOs. They are just common human beings which have to do common work like driving, like speaking in public. They are not able to perform this, and because they are not able to perform such simple job, they are not able to get employed. And if you are mother, you are not able to do good parenting because you require a lot of other skills. Don't think only CEO or MDs require a lot of cognitive skills for day-to-day work like parenting. For driving, you require as much cognitive skills. So this, I will conclude with example of this young woman who had 4 years back severe traumatic axonal injury. She was in coma for more than 3 months, aggressively treated in ICU, tracheostomy, rehabilitation. And why she came, I will tell you why she. So Summarizing, the primary axotomy is a mechanical lesion of the axon which occurs at the moment of trauma, followed by secondary axotomy involving apoptotic and degenerative processes like hydroxylation of proteins, especially at the level of microtubules. Both primary and secondary axotomy may be the cause of coma despite the absence of increased ICP depending on the foci of injury like bilateral thalamic and brainstem reticular formation. The classical Adams classification has never been validated in MRI studies like grade 3 TI seen on imaging studies and sometimes used as a marker of the severity of lesion has no proven association with outcomes. And traumatic axonal injury should be treated the same way as severe traumatic brain injury. But centers with interest in TBI research should be aware of bench to bedside research efforts to participate in clinical trials. And as with other investigated therapies, timing is essential. The window of opportunity between primary and secondary axotomy is short.